Dear friends and colleagues, now I'm going to talk about treatment on neuromuscular scoliosis, and I will try to explain how we make our decisions and how we are going to perform the surgeries, and pros and cons, also the possible complications for this type of scoliosis. As you can see that the spine is straight, but in neuromuscular scoliosis, due to the different reasons, the spine has a long curvature, and also there will be a pelvic obliquity in most of the patients. I will show you some examples how they look like in X-rays. And this is a collapsing spine if the patient has the hypotonia, and this is a severe hyperlordosis with severe pelvic obliquity. So this will enlarge in the sitting position. And let's say if the patient have the muscular or neurological problem at the lower extremities, when they don't have the sitting balance, they have to use their hands to have the ability to sit down. So then they become a quadriplegic because they cannot use their hands for different activities. So that's why most of the time, even though we know that they are not going to able to walk sometimes, but we would like to rescue their upper extremities to use in such as for eating, reading, writing, and using their upper extremities for the productivity. This is the one of the most important aspects of why we are operating these patients. And here again, maybe the patient doesn't have a severe pelvic obliquity, but you will see that in this X-rays, there's a big shift of the thorax and the abdomen comparing to the pelvic anatomy. So the reason for neuromuscular scoliosis, usually neurological systems, muscular systems, or the combination of these. And when we look at the specific problems, if the patient's main issue is the central neurological causes, central motor neuron involvement, then they have cerebral palsy, hereditary ataxia, syringomyelia, or encephalopathy or Rett syndrome. If the main problem, peripheral neurological causes, this could be due to acute anterior poliomyelitis, infantile spinal amyotrophia. If it is peripheral motor neuron involvement, then it could be hereditary motor and sensory neuropathy, hereditary sensory and vegetative neuropathy, which we call it familial dysautonomia. So the mixed central and peripheral neurological causes usually come as with medullary lesion, myelodysplasia, or myelomeningocele. And the last one could be neuromuscular junction problems, which is the myasthenia, and the muscular causes. There are Duchenne myopathy, other muscular dystrophies, and arthrogryposis. So these are the problems, main problems of the patients. And then these muscular or neurologic or the combination of these main problems may initiate the deformity in these children. So when we look at the incidence of scoliosis, In cerebral palsy is 25%, myelodysplasia 60%, spinal muscular atrophy 67%, cerebral palsy 4 limbs 80%, Duchenne muscular dystrophy 90%, myelodysplasia at the thoracal level 100%, and traumatic paralysis if the patient is under the age of 10, again the 100%. So this is very important information, because we know these patients followed by the pediatricians, physical therapy doctors, and also the pediatric neurologists. So our job should pass this information to these doctors to understand that if they have these, if they have the patient with these pathologies, they have to be aware of the incidence of scoliosis. So if they have a patient with Duchenne muscular dystrophy or myelodysplasia or traumatic paralysis, that means these patients 100% will have the deformity, either scoliosis or kyphosis or kyphoscoliosis. So if they send us these patients, they consult these patients as early as possible, then we will know that what time and when we are going to operate these patients. So when we look at the physical examinations, the signs of neuromuscular scoliosis, leaning or uneven sitting posture, as I said before, this is very important. In some cases, pressure sores are quite important for daily quality of life of their patients. Using arms for sitting is a real issue, and it's really worsen the daily quality of life of these patients. Uneven shoulder heights, head of center from the rest of the body, uneven hips and buttocks, uneven shoulder blades, and arms hanging unevenly. These are the signs of the deformity. So when we look at the spinal deformity pathologies, we can explain like this. In central neurologic pathology, for example, spinal deformity may be induced by disharmonious control of trunk musculature around the spinal axis, progressively worsening due to a lack of effective muscular compensation mechanism. So again, the clinical assessment, we have to check muscles. Are they hypertonic or hypotonic? How are the joints, especially the knees and hips? Because these contractures are really important in terms of how we are going to plan the surgery. And also, we have to look at the collapse. For the clinical assessment before the surgery, the respiratory function assessment is very important of the outcome of the surgery. Swallowing disorders are also very much effective for the complications, epileptic state, and most importantly, the nutritional status should be very well evaluated and controlled before and after the surgery. So the cardiac assessment is also a very important issue because when we decide to operate, the anesthesiologists, caregivers, intensive care doctors should understand that some of these patients with specific disease have either cardiac insufficiency or conduction disorder. So we have to beforehand diagnose these problems, and we have to take the measurements during our treatment period. As a result, these changes can further impede a child's independence, making daily activities such as dressing and eating more difficult. Progressive deformity may reduce the space in the chest for the lungs and cause breathing problems. So that's why I'm insisting to teach the natural history of these specific diseases to the pediatricians, pediatric neurologists, and also the physical therapy doctors. So, as I said before, we have to check the nutritional status, lung and heart function, functional level, joints and extremities for contractions, and the ambulatory status of the patients. These are the main factors for the surgical technique and postoperative possible complications. The evaluation also should be done with radiodiagnostic techniques. Bone density is important. Sometimes we need to have the muscle biopsy to understand the pathology, and also if possible, not always possible because of the patients coordinate with pulmonary functions tests, but if possible, we should do that. So non-surgical approaches will be wheelchair modification. Bracing is a huge question mark because the bracing is also embrace the body, and they have the lung and respiratory problems. If you put a brace around the chest, then this will also negatively affect the pulmonary functions. For Duchenne muscular dystrophy, there is a therapy with steroids and also with SMA. Last few years, there is a treatment modality, antisense oligonucleotide medication. It's very, very, very expensive, but this will really reduce the risk of the deformity. So indication for surgery, the curves greater than 50 degrees, difficulties sitting and functional, pain, and problems with heart and lung function. When to operate, this is a real issue. I will say not too late, not too early, but you can ask me that, what does it mean? So this is a kind of experience that you should perform the surgery not before the patient start to trouble with pulmonary or heart functions and also sitting problems, but not as early as they need a growth. The goals of the surgery: correction and stabilization of the spine, balance the spine and pelvis, improve the preserve the lung function, restore the ability to sit upright. So the surgery strategy, two different: T2 to pelvis, T2 to lower lumbar. If the patient is ambulatory, small pelvic obliquity, flexed or non-specific patients can be operated from T2 to lower lumbar area. So the possible complications higher than other scoliosis surgery: wound infection, respiratory complications, implant-related complications, problems due to excessive blood loss. Pelvic obliquity could be upper origin or lower origin. The upper origin is due to asymmetric retraction of the muscle connecting to trunk to pelvis. The lower origin is the contractions of the hip, adduction, flexion, internal rotation. As you can see here, the mechanism of pelvic obliquity is shown on the drawings. This is how you can correct the pelvic obliquity. You can have a foundation in the upper thoracic level and the lower lumbar, upper lumbar level. Then you have the foundation of the ilium. Then you connect and you correct the deformity. So I will show you some of my case again. This is a 24-year-old boy with severe SMA, with severe respiratory problem. And this is outside of my country. And they went to different countries to ask for the surgery. But the patient has a severe respiratory problem. he has not in good condition while in 90 degrees sitting position. He needs oxygen therapy with the some machines. So at this point, we talk with the family about the possible problems, especially after the surgery. We told them that we may need a tracheostomy, and maybe after the surgery, he may need a home ventilator. So after the surgery, we finished the surgery, we achieved a good correction and sting balance. Yes, we had a problem with respiratory problem. We couldn't win the respiratory machines. Then for a few days of follow-up, we did the tracheostomy, and eventually after 1 month of hospital and ICU care, we were able to send him back to his homeland with home ventilator. So this is a poliomyelitis case, operated 4 times previously, had a huge deformity with broken instrumentation, not adequate instrumentation and surgery had performed previously. So for this reason, the patient has a problem of pulmonary problems and also had pain. So we decided to proceed with the posterior vertebral body resection. So we performed the posterior PVCR on the mid-lumbar level, try to achieve a good balance of the spine. So this is again 3 years old female with CP sequelae, unable to walk with this deformity. As you can recognize here, there's a huge pelvic obliquity, and also she has especially left hip contracture and left leg deformity. So first we decided to correct the sting balance, pelvic obliquity, and the deformity. Then we, as we are orthopedic surgeons, we decided to correct the hip problem. As you can see that we performed the long hip prosthesis, and after nearly 10 months of physical therapy, aggressive physical therapy, now she is able to walk around 15 minutes with walker. So this is a very good example of one of my very early patients. I operated her 2009. I frequently see her. She married. She had a baby. Now I'm following her baby because of some problems. As you can see, with 13 years of follow-up, having a very happy marriage, and also having a baby. So yes, we know the neuromuscular scoliosis is a lot different than the idiopathic scoliosis. It takes so many time and needs a big effort, not only by the doctor, but also by the patient, caregivers, physical therapist, and the whole family. So this is a very simple long thoracolumbar curve, again corrected with posterior instrumentation in neuromuscular scoliosis. These can be treated like it is idiopathic scoliosis, but she has a neuromuscular origin, so we have to obey the rules of the treatment techniques of neuromuscular scoliosis. So thank you very much for your patience. I hope that I have a good chance to communicate with Egyptian spine surgeons, and the near future, I hope that we may have a chance to meet with each other and we improve our friendship. Thank you very much and have a nice summer, enjoyable summer. Thank you.